the comprehensive support approach. So, having said this story, it's not just a fairy tale. When you actually get a patient, life is a bit difficult. So, going back to this ladder actually, just to say the stepwise approach. So, when you stepwise increase your analgesic doses, build up on analgesic doses, and combine with your neuropathic but adjuvants, which is for neuropathic pain, still some patients are there, pain is not under control. So, you don't have any surgical option, you don't have your medications, specifically now, strong opioids. Like you can use for cancer pain patients, but you can't use it for non-cancer pain patients. For two reasons. One is addiction. I think is when you put on opioids, they are drowsy, you can't rehabilitate. So that option is not there. So we have a huge gap actually between end of medical treatment and the surgical options. So this actually is a missing link between surgical and medical options. So how do you treat after this? So you are in the world of misery after that. So interventional pain procedures come to fit into this link basically. So this is the way out. So for any chronic pain management whatever team will have to have this component. Otherwise you will fail, because there are patients who are refractory to all these medications we use and don't have a surgical option. So then we are basically lost. So what is IPM? IPM is actually interventional pain management, minimally invasive procedures done on the local anesthesia with image guidance. And what we are basically hunting for is pain generators. As a nociceptive or neuropathic. To find the pain generator, try to modify that. Try to utilize that. So the pain will be controlled, at least if not cured. So this is actually missing link in pain management. It's an indispensable part, integral part of any chronic pain management scenario. So what are the flavors of interventional pain management? We have injections, we have ablations, electrostimulation, surgery. Surgery I'm not going to talk about. Injections wise, we have local injections to the local sites of pain, spinal injections, intrathecal peritoneal systems. Local injection wise, we can do diagnostic blocks with local anesthetics combined with steroids. There will be some therapeutic effects, outlasting local anesthetic effects. Ozone has come a big way into this thing, injection treatment actually. Ozone has certain properties as antiseptic, used to sterilize theatres and various other instruments nowadays. Ozone also have some neurotic properties. So if you inject into a, say, joint, knee joint, your knee joint pain will disappear for some time. Same like steroids, but it doesn't have the bad effects like periarticular osteoporosis. If you inject steroid into a joint for some time, after that you can replace that joint because there will be a lot of periarticular osteoporosis and you can implant and put up processes in there. So ozone will not have that effect, it will just neuralize the pain fibers. And thirdly, ozone has some desiccative properties. So if you introduce ozone into a bulging disc, not completely bulge out, sequestrated, the disc will be shrunken. So that minor compression, pain predominant disc bulges, don't have neuropathy, motor-sensory dysfunction. If you introduce ozone into that, you get sometimes very good effects. Same as surgery. Then intrathecal drug deliveries, I'm not going to talk about very much. And for vertebral fractures, mainly osteoporotic as well as cancer related vertebral fractures, we can do vertebral injections of PMMA, polymethyl methacrylic acid, which will restore the height plus give some pain relief. Then ablation wise, we have some cold treatment, cold therapy, and radio frequency, which is actually a burning sort of thing, where we apply heat with that. So the difference between ablation, whatever, and the injection is injection. We have control of only the injectable volume. You inject something, it will spread. Sometimes it will spread to important structures also. It's a risky thing. Whereas ablation is more targeted, like diathermy. You pinpoint the structure, diathermize it, and the pain will be basically suppressed. Electrostimulation, the same gate control theory comes into play with this. like applying a soothing balm. What you do, you stimulate large fibers. You can do it in the periphery, do it in the dorsal column, and what happens is the large fibers will be, pain fibers will be inhibited, so you get basically pain-free sometimes. So this basically is very important in sympathetic mediated pain as well as sometimes failed back surgeries. You can't do back surgery again, your back is already gone. There's no option otherwise other than implanting a small electrode into the spinal cord and then stimulating it. It's like a pacemaker, very small machine. Still expensive, but in the time to come in Chinese people start producing, it will be 2,000-3,000 rupees. Simple 30 minutes.